Welcome to DentLinks, our website. My name is George Tawil, and I'm very happy to share with you this very interesting case that I have been following for the past 40 years. When the patient first presented to our consultation in 1978, patient is a male patient born in 1951 with no systemic problems to report, and at the time of consultation was under no medication. He is a very heavy smoker. So we did the full clinical and radiographic examination that I'm showing here. You can tell that the patient at the age of 27 had already several dental treatment done for the treatment of decay and endodontic problems. When he consulted, he was in pain because of a decay invading the pulp on the mandibular molar. Patient has a fear, dental phobia. He is very resistant to any treatment. We diagnosed noticeable bone loss. Bleeding on probing was in the range of 30%. Pocket depth 4 to 5 millimeters. The patient is not compliant. He is not careful at brushing his teeth. He doesn't like to go to dentist unless he is in very severe need, like in this particular case. So we suggested an overall treatment planning of repairing the damages that were present on his teeth, do a comprehensive periodontal treatment, put him on a regular maintenance program. We did 2 visits of scaling and oral hygiene instruction, but the patient disappeared back in 1986 in such a condition. The bone loss has progressed over the past 8 years, and we noticed that the furcation started to be invaded, and in the molar area, the mandibular right molar, tooth number 47 was very mobile. Tooth number 17 had to be extracted because of very severe mobility. So we noticed that in the past 8 years, the periodontal disease has progressed quite dramatically. So it's not anymore a situation of a chronic periodontitis, it's rather a more aggressive form of periodontitis on this young adult. So we urge him to have a good treatment plan, a good treatment done, and most likely insisting on the maintenance of his periodontal condition. You can tell from these x-rays that he has been neglecting himself quite a lot. He has recurrent decays under the crowns and mobility on his posterior teeth. He received 1 visit of cleaning in our office, and then he died in 1995. So the fear, the dental phobia, is one of the reasons why he couldn't have his treatment done appropriately. So when he showed in 1995, quite an extensive dental treatment was done to stabilize his teeth, no periodontal treatment. Simply stabilization using fixed bridges and root canal treatment on several teeth. The teeth were barely holding in the sockets, very severe bone loss on the mandibular anterior teeth, and the posteriors were lost on the right side already. So it was a time where we really had to have a complete, comprehensive perio and dental treatment. And we presented this to the patient. The patient again refused the treatment to come back in 2001 when he had no choice but to have his treatment done. We decided at that time to do an implant-supported fixed restoration in the maxilla and the mandible. We proposed the treatment to the patient. He accepted because he had no more choices. We said this treatment will never succeed unless the patient is under a very careful maintenance program, and at that time he agreed on that. He wanted to have the treatment done in a phase, sort of starting with the mandible, and then when he was more secured about his result, then we move up to the maxilla. So we agreed on this protocol, and we decided to start the treatment in the mandible. Started the treatment in the by placing 6 implants in position 46, 44, 42, 32, and 34, 36, altogether 6 implants for a mandibular rehabilitation. Implants were placed in October 2001 and connected in May 2002. And with that, he had 3 bridges, uh, one on the anterior mandibular implants between 42 and 32, and 2 on the posterior implants. He insisted on having his canine saved. These were the only teeth that could be saved in his mouth. They were quite stable at that time. So we kept the canine. And when he was satisfied with his mandibular operation, he decided to have his maxillary treatment done. So all teeth were extracted in May 2005, immediate implant placed in the fresh sockets. Residual defect was filled with anorganic bovine bone. Guided bone regeneration was done where the defect was more severe. Abutment were connected, and implant supported temporary fixed restoration was placed in the maxilla. So the patient was now in function again. Aesthetics is fairly saved. He is doing a better oral hygiene. He is under a more careful maintenance. So 2005 was done, and then final reconstructions were done in the maxilla. 2 bridges were placed on in the maxilla on the implants inside the central incisor, canine, and molar on the right side, and the same on the left side. So the patient was on a 6-month recall program and maintaining quite a good oral hygiene. This is a situation in 2009, some 4 years post-treatment in the maxilla, and 7 years in the mandible. Peri-implant bone loss was fairly stable. The maintenance was done. There was not much bleeding or probing on all the postoperative visits, and the patient was maintaining quite a good oral hygiene. This is the clinical situation in 2010 or 11. 2012, the problem started. Peri-implant infection developed on the implant site 44, pus, exudate, bleeding. So that was 10 years post-treatment in the mandible. We attributed this infection to his history of advanced periodontal disease, his smoking habits. Although he was under a good maintenance and cleaning properly his teeth, probably susceptibility to microbial plaque is one of the causes for this infection to start. So we said we have to treat this. So we went on and opened a flap. The canine, the adjacent canine that hold it for 10 years now, was extracted because of mobility. It was replaced with another implant, and the infection on site 44 was curated, clean. The implant surface was, the threads on the implant surface were removed. This is a peri-implant, this is a thionite surface. It was decontaminated using a mixture of chlorhexidine and iodine, hydrogen peroxide, and sprayed with sterile saline solution. The defect was filled with anorganic bovine bone, covered with a collagen barrier. And here we see the X-ray after treatment and the canine in place after it has been restored. So we thought this was an infection that was related to his history of advanced periodontal disease. The patient should be under a more severe maintenance program, so he was coming on a regular basis for cleaning. His oral hygiene was, I should say, relatively acceptable. No plaque collection, except that he's still smoking. In 2014, another infection declared on the maxillary anterior implant, site 11 and 21, and that started getting a little bit more worrying. We opened the flap, we cleaned the area, curated the area very thoroughly, The surface of the implant were not, the threads were not removed. We only decontaminated with chlorhexidine, iodine, washed the surface with hydrogen peroxide, following the same protocol, except in that case we did not remove the threads on the implants. And the graft, non-organic bovine bone, was placed in the residual defect, as you can see on the screen. And the graft was covered with a collagen barrier, and the flap sutured back again in place. We thought we could have a good result. In fact, a few months later, the infection recurred. And we were in a situation where, because of this quite severe infection, to explant the two implants, remove them due to this recurrence. We didn't want to go into further bone loss that could really jeopardize the aesthetic and the function, most likely the phonetics of this patient. So we suggested to the patient to have these two implants removed, another two implants placed inside 12 and 22 lateral incisors, separate the bridge at the level of the canines, and place another 4-unit bridge on the newly placed implants. So the patient refused this approach. He said, "Can I stay as I am for as long as I can?" So finally, the two bridges in the maxilla were holding on the right side on two implants, and on the left side on another two implants. We thought that we had to maintain the situation to the best that we can, and we put the patient under a 4-month recall program. He was maintaining quite a good oral. In 2016, about a year later, another infection started on the implant placed inside 42. That implant was placed in 2001, so 15 years earlier. The situation started to get even more worrying at this stage. We did the same protocol, curettage, and so on. The patient is a little disappointed and couldn't understand why he had so many infections, although he was on quite a regular maintenance program and maintaining, to the best of his ability, an excellent oral hygiene. So the site again was curated following the same protocol of curettage, decontamination of the implant surface, and grafting of the defect with anorganic bovine bone, and placing a membrane and suturing the flap appropriately. Another few months later, another infection started on the upper canine. Again, the same protocol for treatment of periodontitis and treatment, curettage of the site, removal of the threads at this point of the implant, and decontamination of the implant surface and grafting it. 2017, the two implant placed in the mandibular right side practically explanted. There was so much infection that developed in such a short period of time. So there, when we removed the two implants with the bridge, we started worrying about the possibility of having a cause that is not the cause that we suspected in the first place, that is the history of periodontal disease and his smoking habits. Something was there that we could not understand, and for that reason, we thought that we started to need to investigate more his systemic condition, refer the patient to the allergologist. And we wanted to know whether he was allergic to titanium. So the allergologist ran the test that was available to us here. It's called the TRUE test. It's a ready-to-use patch test, normally used for the diagnosis of allergic contact dermatitis. It tests for 32 allergens, and the conclusion of the dermatologist was, the allergologist was, severe allergy to titanium. So we know from the literature that this is a very rare occurrence. The study done by Cecilia, published in 2008, reported a percentage of 0.6% approximately of patients can be in that kind of situation. Now that you have to do with the new etiology, a clinical situation that we haven't really treated before, we thought that we had to change the implant that we have placed so far on this patient, and to use zirconia implants on this mandibular right side. So two one-piece zirconia. This is the ITI Straumann implants, We placed 2 implants on the sides where we had the previously placed the titanium implants. The residual defect was filled with autogenous bone, and we waited 3 months for the implants to integrate. And when we had a good clinical results, we moved on, and our prosthodontist placed the 3-unit bridge on these 2 implants. So to say, we have switched to the cornea implants because we had the evidence that there was an allergy to titanium. Whether zirconia is not prone to periimplantitis is not correct. The literature is there to demonstrate that periimplantitis may also occur on zirconia implants. That zirconium didn't show any lower bacterial colonization potential than titanium. The osseointegration on zirconia is quite similar to titanium, so that we can use it clinically as a support for implant for restorations. The only thing here is that we didn't have any more to deal with the situation of allergy to titanium, but we have to be very cautious on maintaining the patient because zirconia also can be subjected to periimplantitis. The canine was lost on the other side 15 years after we started the treatment, so we extracted it and replaced it with another zirconia implant. In 2018, another infection on the maxillary right area, so practically every implant in this patient now developed periimplantitis. Now that we know he's allergic to titanium, what shall we do? Shall we remove all the implants and replace them with the zirconia implants, or treat as the situation comes with the means that we have of controlling periimplantitis? The patient said, let's start with this. So we, again, opened a flap, curated the site, followed the same protocol, except that in some areas we did remove the implant threads, and in some other we did not, but we followed the same clinical protocol of curettage and implant surface decontamination and grafting. Even in that particular case, we tried to use ozone to decontaminate the implant surface. Didn't prove to be effective. So we had to go to the regular protocol of treatment, that is curettage and bone graft. This is the situation today. On the side that we treated for periimplantitis, we had several years after quite a good control on the condition. The side there where we placed zirconia implant, we had a stable result with no infection so far. Probably more infection will develop in other places than the mouth. But with the protocol that we have been following, we are able to maintain this patient in function in spite of his very severe risk factors that are his history of periodontal disease, smoking habits that are more under control now because he realized that it was urgent to take important steps in order to control the infection and the chances of having infections. And this now newly coming out etiology, that is the allergy to titanium. So all we can say today that in spite of all that we have, we are trying to the best of our ability to maintain this patient in function, as little intervention as we can, putting him on a 3-month recall program to control as best as we can the plaque formation in the mouth, and enhance as much as we can the oral hygiene. This is a situation 40 years after we have started treating this patient. And we will keep on following this patient and giving you all the information as they come on our DentLink website. Thank you for your attention.